Good morning, everyone, and thank you so much for joining us today. I am Shelley Fold-Nasso, and I'm the CEO of the National Coalition for Cancer Survivorship. We're really excited to have Dr. Otis Brawley joining us again. Otis, you have helped us many times throughout this pandemic by, you have such a great way of explaining what we know, what we don't know, and what you think based on the evidence that you've read, and helping us make sense of what the risks are and what cancer patients and cancer survivors need to know. Dr. Brawley is a Bloomberg Distinguished Professor at Johns Hopkins University, and as of last summer, he is a member of the NCCS Board of Directors, and we are so grateful to have you as officially part of the NCCS family. You were always one of our favorites and our go-to experts, and really grateful to have you on our board. So I'm going to turn it over to you to just tell us kind of the current state of affairs with COVID and what cancer patients need to know. And then we will take questions. You can ask your questions using the chat function. And I've got already a bunch of questions that people have sent in when they registered. But first, I'm going to let you just lay it out for us where we are now.
Well, first, thank you for having me. It's always a privilege to be with you and with the folks from NCCS. It's been 2 years. It's been 2 very hard years. We've lost 967,000 Americans as of yesterday. 5 million people in the world. Yes, 1 out of every 5 people who died from COVID are from the United States. And since we're about 5% of the world's population, it means we haven't handled the pandemic very well. We've lost about 1,000 kids, by the way. The death rate was averaging 2,500 deaths per day in late January, and today it's somewhere between 950 and 1,000. So we've reached a nodal point. There have been now 4. We don't know if there's going to be a 5th. We've learned a great deal. It's actually a tribute to the scientific process as we look over the last 2 years. Keep in mind, this time 2 years ago, we did not know that asymptomatic people with COVID were contagious and could give it to other people. And when we found that out, that became the basis for why masking was recommended. We did not know 2 years ago that the virus would mutate as easily as it mutates, and that's the reason why we've had alpha, beta, gamma, delta. The infectivity of the virus. We knew that viruses follow Darwinian principles, and the virus doesn't want to kill its host. The virus wants its host to live so the virus can live, and the virus wants to be more infectious. And so we knew that those sorts of things happened, but we didn't realize that we would end up with a Delta virus, which was far more infectious than the Alpha virus, the original COVID that we had. We didn't know 2 years ago who would be affected. It certainly seemed to be more older people getting the disease. We now know that people who have comorbidities and people who are over the age of 80 are at much higher risk of having a bad outcome from coronavirus. 2 years ago, most of us didn't know what a messenger RNA virus was, and a company called Moderna, which started up to make messenger RNA vaccines for cancer treatment, was on the verge of bankruptcy, believe it or not. And they turned that messenger RNA technology that was initially developed for cancer treatment into a vaccine, which now is a drug which has prevented probably more deaths than any drug in the history of the drug industry. We now know that people with cancer who have solid tumors are relatively very much like people who don't have cancer, as long as they're healthy with those solid tumors. And people who have lymphoma, especially B-cell leukemias and lymphoma, are at higher risk of the disease, and the vaccine doesn't work as well in those folks. And so we've come up with a bunch of treatments. The IL-6 inhibitors first used in CAR T-cell therapy are very useful in saving the lives of people with COVID. We've now got even oral antiviral medications for our viruses like COVID. We will learn a great deal more. And indeed, one of the good things about the COVID pandemic, if there can be some good things, is we've learned a great deal of molecular biology and science, which is going to help us in cancer and other diseases. And then, of course, we've all learned a little bit about testing. In the recent past, partly because people are just tired of being masked, and partly because the death rate is going down. The number of deaths per day is averaging about 950 to 1,000. And it was 2.5 times that a couple months ago. We are starting to get out of masks and get and letting our guard down a little bit. And if one thing I can say to this audience today, especially the cancer patients, especially cancer patients with lymphomas and leukemias, and especially cancer patients with B-cell malignancies, don't let your guard down too much. Still try to practice some distancing, especially when out in public. Wear masks, wear high quality KN94 and 95 masks or N95 masks. We can talk a little bit more about what those are. Make sure you have a high quality mask that can protect you from other people. We traditionally told people wear masks to protect other people from you, the individual. Now we're telling people who are at high risk that they need to wear masks to protect themselves from other folks in the public. And I'll stop at that point and let's dive into some questions, shall we?
Well, okay, so I'll start with that on the mask. So tell us a little bit more about why that's changed, because the messaging was, it's to protect others from you, and now we're saying that it does protect you. Can you talk a little bit more about that, and also a little bit more about what kind of masks?
Sure. Remember when this all started, there was a shortage of masks.
Right.
Telling people to use dish rags, and we had the Surgeon General showing people how you can make your own mask at home. We didn't want to take masks out of the medical environment because there was the shortage. And with a regular quality surgical mask, even, and certainly something that's made at home, those masks only protect other people from the person wearing it. It keeps the person who's wearing it, keeps their particles in their breath from going out into the environment so they can be inhaled by other people. They're much better at stopping things going out than they are at stopping things that you're trying to inhale in. And that's true of all the masks that we have, including surgical masks. We in surgery, when we go to surgery, doctors and nurses and technicians wear those surgical masks to protect the patient from them, not to protect the people doing the operation. The mask that actually protects the individual wearing it is a N95 mask or KN95 mask. Now, those masks in the medical setting traditionally have only been used when we're dealing with folks who might have an infectious disease like tuberculosis or respiratory virus. And those of us in medicine, there's even this ritual where they go through to fit the mask to the face appropriately and spray a sweet smelling mist. And if you can taste the sweet smelling mist, your mask is not fitted to your face appropriately. And even don't allow doctors and nurses with beards in the environment where they're wearing N95s, because those masks don't fit appropriately. During the pandemic, we started using PAPRs, which is sort of like a little space helmet for people as well. But getting to the mask, only the N95 and KN95s protect the individual who is wearing it from people outside the environment. In many respects, I and other health professionals wished we could keep people in masks now, to protect the vulnerable. But public health has come to realize that keeping people in masks for more than 2 years straight just isn't going to work. People are going to stop listening to us on things that are even more important that may come down the pike in the future.
So can you talk a little bit about, you talked about the scientific process has really informed all of this, but I don't think people really understand that. And so then when things change, it's that you were lying to me or you didn't, it seems like we've done a really not a good job of communicating both what the scientific process is, why it's normal for things to change, what the expectations were of the vaccines, that they weren't necessarily to prevent you from getting it, but to prevent serious illness and death. So how can we get better at all of this communication? Because I think, in general, we've done a bad job. And then people use that to sort of reinforce what they already believe or want to believe.
You are so on target. The issue, unfortunately, is science evolves. We try to communicate so frequently in the 30-second sound bite. The reason why I love sitting down and talking to you is you give us an hour and you give us the ability to develop something. And it doesn't have to be succinct and in 30 seconds the way CNN pushes you out there to do it. Sometimes what people want to say requires more than 30 seconds. And the fact is, as you said, science evolves, our knowledge evolves. There was a time, I especially remember when Dr. Fauci, a wonderful man, by the way, I know him personally, when Dr. Fauci said people don't need to wear masks. What he was really saying is the science as we know it right now says that we don't need to wear masks because right now we don't have evidence that asymptomatic people can spread the virus. Now, when they developed that science, when the science told us asymptomatic people are spreading the virus and are contagious, that's why things changed. Mm-hmm. And, it's a little, perhaps a few more people would be more accepting if we explain why the recommendation changed.
Right. And that I don't know that we did that great of a job with.
We did not.
Or, people weren't necessarily open to it because they wanted to sort of use it to sort of bolster their point of view. You talked about it's not feasible to keep people in masks for 2 years. I'm a little concerned that if we do have another variant that comes, it's going to be really hard to get people back to using masks if it becomes necessary. What do you think?
I agree with you wholeheartedly. I think that's going to be a challenge. And I'm not 100% comfortable with people coming out of masks right now. I'm still wearing my mask in most instances, especially in grocery stores and in public. But I was at a medical meeting about a week ago. It was the first medical meeting I went to in over 2 years. And I was taken aback, as was several of my infectious disease friends. We were in a room with 600 doctors, and I would say about 5% of us were masked.
Wow.
It was in Florida, which, by the way, Florida is the United States has the highest COVID mortality rate in the world. Literally 20% of all COVID deaths are in the United States, which is 5% of the world's population. And there's certain areas of the country that have even higher risk of death, partially because Florida has it partially because there's a lot of elderly people there, and partially because their public health response has been wholly inadequate. People have died because of political malpractice.
Yeah. So you talked about people who have had leukemia and lymphoma and B-cell malignancies needing to be especially not to let their guard down. What about other cancer survivors? And is there a way to tell to what degree you may be immune compromised? Who needs to be worried if you're still in treatment, if you've completed treatment, if you have stage 4 with no evidence of disease? These are a range of questions that we got, but
Sure.
and also just I want to mention one thing. One report I heard on NPR a few weeks ago, where I think they surveyed people on their concern about COVID, and basically what they found is the people who are least at risk because they had been vaccinated, boosted, wear masks, and all of that were most concerned, and the people who were most at risk because they had not been vaccinated and didn't wear masks were the least concerned. So that we have sort of this mismatch between what we think, what our concern level is and our actual risk level is, but does that actually translate to cancer survivors as well? So I think I asked you about 5 questions in one.
Sure. The people who are most concerned are the ones who are vaccinated. And that's the reason why they got vaccinated, because they were concerned. The folks who we worry about the most are people who have leukemia, lymphoma, especially B-cell malignancies, and then people who have solid tumor cancers who are currently getting treated, especially people who are getting treated with steroids. But anyone who's getting a treatment that is immunosuppressive, where their white count goes down, those folks are at higher risk. Be they vaccinated or not vaccinated, they're at higher risk. And the folks who have B-cell malignancies especially are at higher risk because, for lack of a better scientific term, even though they may be vaccinated, the vaccine may not take. It may not work as well in someone who has multiple myeloma or someone who has B-cell lymphoma as it would work in someone of the same age who does not have a B-cell malignancy. And so there are some cancer patients who are triply vaccinated, or some folks are now getting a 4th vaccine, who, despite the fact they've gotten vaccinated, the vaccine is not going to be as protective of them. And those are the folks I really worry about. And those are the folks who really do have to keep their guard up.
And when you talk about those patients, the ones with B-cell malignancies, are you talking about that are currently in treatment for that, or that have had that in the past?
That's an excellent question. I'm more worried about the people who are in active treatment, but I have some worry about people who have had a B-cell malignancy and are in complete remission. Okay. Folks, we still don't know. We know that they had a problem in their immune system. That's why they got the lymphoma to begin with. We don't know how those folks are going to respond to the vaccine. We don't know how those folks are going to respond if they get infected. And so I still have some worry. Please, if you've had any cancer, keep your guard up. If you've had a leukemia or a lymphoma, keep your guard up even more. It's more important there.
And is there any testing of your level of immunity that's useful?
We're still arguing about that. We've been trying to look at antibody response to the vaccine, and there's still a great deal of confusion in medicine and a not total understanding. There is a test where you can get your blood drawn, and it can say you have antibody to the virus. You've responded to the vaccine, but we're not able to quantify that response well.
Mm-hmm. What about if you've had it? Like, I know so many people got it in the Omicron wave, including me and my family. Like, how long do you have any kind of natural immunity? Do we know how long that lasts? Because I know that it's not forever. One of my sister-in-law got it. She was vaccinated, boosted, and still got it twice. She got it with the Omicron wave after having had it last year as well.
Now there it gets really complicated. There are people who get infected with Delta, and 4 or 5 months later, after they're fine from the Delta, after they've recovered from Delta, they still have antibody to Delta, but not to Omicron.
Mm.
And
Okay.
there are people who have had Omicron now, who, if we have another wave, will be susceptible, even though they have good immunity to Omicron. This messenger RNA, this RNA virus changes so frequently. And the other thing, by the way, I should mention, because there's a lot of criticism that we were flat-footed and did not have enough tests when Omicron came around. The first question that the scientists and the infectious disease people were asking is, does the current COVID test, especially the home COVID test, does it work for Omicron? We know it works for Delta. Does it work for Omicron? So we may have another, hopefully we won't have another mutation or another strain come along. But the first question they're going to have to ask then is, do our current therapies and do our current diagnostics work for this new one? By the way, remember in Omicron, some of the original monoclonal antibody therapies that were developed and before did not work. 2 of the 3 monoclonal antibody therapies that were marketed did not work for Omicron.
So is there any way to know if you had COVID, which one you had, whether you had Delta or Omicron or a different, the original strain? I guess some of it's timing, but Delta and Omicron, there was probably
Overlap.
some overlap.
Yeah. The only way that you can know is if you happen to be a patient in one of the big medical centers where they're doing a lot of research. There's some laboratories that can look at your antibody titers and tell you which kind you had. Now, that's not really commonly available, and there's no FDA certified tests for that purpose. These are all experimental things, but there's some people who I know who have done that.
So what about, I've been reading a little bit about this BA2 variant and the cases going up in Europe, and in the past waves, we followed what happened in Europe. What do you know about that?
Well, there's actually a number of different mutations that have come up. Some of them have caught fire and gone around the world like Omicron. Some of them just sort of fizzled out. You might recall there was a South African variant early that we were really worried about, and it became a problem in South Africa, and for reasons we still don't know, it just sort of died out and was replaced by something else. You can also get a crowding out effect where you can get a variant like Omicron, which actually in a way suppressed Delta. Delta won because it was replaced by Omicron. And it's just a crowding out issue. It's a space, I think that's a good analogy. It's just crowding out. This thing gets more infectious. And by the way, there were some studies that I still the ethics of that were done on healthy volunteers in Britain, where they would take viral particles and squirt them up the nose of a healthy volunteer. And with the original alpha strain of COVID, you had to squirt 10,000 viral particles up a person's nose, and there was a 50% chance this healthy volunteer would get COVID, unvaccinated healthy volunteer. With the later Delta, it was about 1,000. So you go from 10,000 to 1,000 viral particles. That means Delta was 10 times more infectious than Alpha. When we got to Omicron, it was 100 viral particles up the nose. So it's 10 times more infectious than Delta. It's 100 times more infectious than Alpha. So this is infectivity. For those who like to do chemistry, we can even talk about the binding of the spike protein on the virus to the ACE2 receptor, which is how it enters into the body, but it's binding coefficients for those who do chemistry.
Hmm. Now, was the Omicron variant, was it milder, or was it just that so many people who were getting it were vaccinated and boosted and therefore had milder disease?
Interesting question. We don't know on this one. We think Omicron was milder. There's this principle of Darwinian virology, and Darwin even gets into virology as well as other things, that viruses do tend to want to become milder and less deadly because they don't want to kill their host. They want to live in their host.
Right.
And so we think Omicron was a milder version, but interfering with that is, as you said, so many people have had the previous COVIDs, so many people have now been vaccinated, and so we really don't know.
Mm-hmm. Is there any evidence that healthy lifestyles can have any protective value for COVID?
Yes, absolutely. There is evidence that people who, for example, work a lot and don't get a lot of sleep actually do run down. It's not just that they start doing things that put them at higher risk, like forgetting to distance, forgetting to wear masks appropriately and so forth, but they run down their immune system and they may become more likely to get COVID and other viruses as well. Also, in the pandemic, we know that people who are overweight, people who are diabetic, especially people who are diabetic whose blood sugars were not in order to begin with, those folks were more likely to do badly from COVID if they got sick. In the case of people who are overweight, it was simply the weight of one's body having to raise one's chest to breathe. Those people, some people who died literally had a lot of lung disease from COVID, and then they just got tired because their chest was just too heavy to breathe. We learned along the way, one of the most important things we learned along the way is if you lay people down prone, face down, they actually can breathe better. And there's some people alive today because we learned how to position folks to try to keep them off the ventilator.
Wow. I mean, when you think about all the sort of waves that we went through, or that, at the beginning, ventilators were in short supply, and then it was like we're trying to do whatever we can to keep people off of them, and it's evolved so much. What about with the mask mandates set to expire for air travel? Do you have any recommendation for cancer survivors or people who are at risk traveling? Should they not travel, or should they just make sure to wear the appropriate kind of masks?
If you do travel, please do wear the appropriate type of mask if you do travel. Now, airplanes, something that we're going to pay much more attention to in the future, because we're going to have more pandemics and more respiratory illnesses in the future. We've had a bunch of respiratory illnesses we haven't paid enough attention to in the past, like influenzas. We're going to pay a lot more attention to ventilation in buildings and ventilation in rooms. Airplanes have wonderful ventilation systems, and there seems to be very few people who we know for sure have contracted COVID because of air travel. That being said, I would be I'm not going to tell people do not travel. I will say, if you do travel, please wear a high quality mask, and please try to practice as much distancing as possible. I've seen people on airplanes who wear a mask, but then they start eating and drinking, and it's almost as if they're not wearing a mask for the entire trip. So my advice to people who are immunosuppressed is, if you do travel, wear a mask.
And how many times can you wear KN95 or N95 masks before you have to replace them?
Oh, I'm terrible with this myself. The rule books say that you should replace the N95 on a daily basis. I tend to replace mine when I see it's starting to get a little dirty. Don't do what I say. Don't do what I do. Do what I say.
Okay. So you mentioned the meeting you were at where there were a lot of doctors and very few wearing masks. What about if you're having an indoor meeting without masks? Do you still need to have, spacing? Is 6 feet spacing, is that still a recommendation?
Yes. Yeah. The spacing is still a recommendation. And the thing that's hard, we shouldn't be shaking hands.
I know you said that at the beginning that you wanted shaking hands to go away forever, and I don't know about that.
Fist bump, the CDC handshake is the elbow bump. Those are because a lot of people, colds and flu are overwhelmingly spread by shaking hands and grabbing the doorknob after someone who just contaminated. Still need to think about keeping our hands clean. We still need to think about hand washing, some distancing. By the way, I went to one doctor meeting and 5% of us were wearing masks. I was at the cancer control meeting that is at the American Society for Preventive Oncology in Tucson just this past weekend, and everybody wore a mask. I felt like I was with my brother, and when I walk into everybody's wearing a mask. Just the contrast between two kids.
Yeah. What about masks outside?
Less needed, especially on a windy day.
Yeah.
But if you're outside and you've got 4 walls but no roof over your head and there's no breeze, maybe you should wear a mask. But if you're outside at any place where there's a breeze, you're fine.
Okay. And then you talked about boosters, and I saw recently that the Pfizer CEO is saying that we're all going to need a 4th shot. Do you think that's true? And if so, will people who are immune compromised need a 5th shot if they've already had a 4th shot? I mean, how many are we going to end up needing?
I think we're going to need future shots. How many, I cannot tell you. My suspicion is that the future of this virus is that it's going to become endemic. I think shots in the future are going to be a little different from shots in the past. Pfizer and Moderna and AstraZeneca are all working on shots that are more specific to Omicron. And so I think that, I wouldn't run out and get my 4th shot, but I'm going to have to get a 4th shot in the future. And the one thing that's good is it doesn't seem like getting shots every 6 months is hazardous to one's health. But it's a good thing. It turns out to be. Yeah.
I know the lack of a shot for kids under 5 has been a huge concern for parents. My kids are all old enough; they're all vaccinated, but I remember those days. And then I can imagine if you're worried about your own health and you've got a 3-year-old who's in daycare and worried about them not being able to get vaccinated. What is the status of that? How important is it that the younger kids get vaccinated? How much are they spreading it to their families? I know I did. My teenager brought it home from high school and got all of us sick. But do the youngest ones spread it among them at daycare and preschool?
That's the thing that I worry about the absolute most. I worry the absolute most about young kids spreading it. Then I worry about immunosuppressed young kids who have leukemia, lymphoma, and that sort of thing. Unfortunately, the vaccines did not work nearly as well as we were hoping for kids under the age of 5. And hopefully they will be able to manipulate the vaccines a little bit such that they can start vaccinating younger kids. But right now, of the 1,000 children who have died from COVID, we've literally had 970,000 Americans die from COVID, of whom 1,000 were pediatric deaths. The majority of those pediatric deaths had a comorbid condition underlying that led to the death. So kids do well when they get COVID in terms of survivorship, although we don't have data yet on things like long COVID in kids. We don't have enough data yet on long COVID in adult survivors as well. And I've said on a previous conversation, in the Spanish flu of 1918, 1919, which by the way did not start in Spain, it's just they had a good health system and were able to pick up the fact that there was an influenza when the rest of Europe was at war. As a matter of fact, we think the Spanish flu started in Kansas.
Oh, really?
And spread to Europe with American troops going over there. In 1953, you start seeing a series of papers that suggest that people who got the Spanish flu of 1918, 1919 were at higher risk of Parkinson's disease compared to people of the same age who did not get the Spanish flu. 30 plus years after the pandemic, they associate getting the disease during the pandemic with a problem, a comorbidity, Parkinson's. In 2050, 2060, we may do the same thing with COVID. There may be things caused by COVID that we don't realize for another 20, 30, 40 years. Now, we already know that there's a bunch of people suffering from long COVID. They have symptoms of being very tired. Some people have depression as well. And we don't know what to do for them. Oh, by the way, the vaccine does help some. Some people with long COVID who were not vaccinated beforehand do improve after vaccination.
Okay, so I've been getting a lot of emails and texts to join brackets for March Madness, and I think everybody's excited that it's back. And but there's going to be packed arenas and masks optional. Or what do you think? I mean, I know we're all ready to get back to normal life, but
yeah, I'm going to avoid even open air footballs and baseball stadiums that are very crowded. When you start talking about a basketball arena, I'm going to avoid all of those things. And my recommendation to everyone is avoid those situations. You don't know who's sitting next to you. And keep in mind, one of the early studies that told us that there was asymptomatic spread associated with coronavirus was a choir in the state of Washington. There was a choir practice, and everybody went there was asymptomatic, but several members of the choir ended up dying of COVID, and they were ultimately able to figure out that there was an asymptomatic person who was contagious. They were also able to figure out from that and some other studies that shouting, singing, all aerosolizes viral particles as people shout and sing, such that other people can inhale them.
Yeah. Okay. Well, I wasn't going to go anyway, but you've convinced me.
If you do go, please wear a high quality KN94 or N95 mask.
Okay. Are vaccinations recommended for everyone now, or are there still groups who are not recommended to have a vaccine because of other conditions or treatments that they may be receiving?
I don't know of any condition over the age of 5 where the vaccine is totally contraindicated. There are a few people who have allergic reactions to vaccines very commonly who should not get the vaccine. And there are a larger group of people who still should get the vaccine, but the vaccine is not as likely to be as protective for them as it would for the average American or average human being. But there's not a particular illness that anyone with this illness should not get the vaccine.
Okay, great. So, thinking about cancer care, what is the recommended practice now for cancer centers related to having visitors and screening for COVID for visitors? I know that was a big challenge for a lot of cancer survivors when they could not bring somebody with them for treatment or for their different appointments. Is that changed now? Are cancer centers allowing visitors again?
Oh, I see patients and I still remember having to, FaceTime with family members out in the car in the parking lot and that sort of thing. And thank goodness those times are gone now. We're loosening up the rules and letting people in. Now in our clinic, we're still requiring people wear masks.
Mm-hmm.
We're at least letting family members in. So that is changing. We're loosening up a little. We're loosening up a little bit there, and that's a good thing. However, I'm paid to be pessimistic. I dread the fact that there's a decent chance we're going to go back to that again if we have another mutation or another strain of virus, and we will go back to that.
Hmm. Is there any way to avoid that? Because I think that, in general, it's hard on anybody, but I think especially, when you have the stress of a cancer diagnosis and you can't take in all of the information, and it's so important to have somebody there with you.
The only thing you can do is we've got very good at using FaceTime and
Mm-hmm.
other things to try to involve family members. That's the only thing you can really do. Ultimately, if it was a perfect world and we could get everybody vaccinated all around the world, we would stop having these mutations and actually maybe even end this whole pandemic.
Yeah. Is there study going on nerves and circulation of the COVID vaccine side effects?
Yeah, there's several. There's several. Some of them for people just with COVID. There's even some specific to people who have cancer, and they're basically cohort studies where they find people who qualify because they've had COVID, and they start asking them questions, and they start looking for trends in those questions, looking at everything from depression. Some people have said that they can't concentrate as well. Some people have said they even can't focus their eyes as well, looking at everything you can imagine. But yes, there's a couple of cohort studies out there for cancer patients of various types of cancer, and then there's one for COVID patients in general.
Okay, great. So people talk about the whole idea of an endemic phase of the pandemic. Are we there, or what does it take to get there? When might we be there? How do we define that?
Endemic means that it's there and you just sort of have to live with it. Influenza has been endemic to us for some time, and we get influenza shots every fall. The H1N1 that made up the Spanish flu is now endemic. By the way, it comes back around every 4 to 8 years. It was last 3-4 years ago that H1N1 was in the regular flu shot that we get every fall. Mm-hmm. Because it reared its ugly head and was people again. I do think that we're going to have COVID endemic to the world, and this thing's going to come up every now and then. And we've had a number of RNA viruses. There are a number of COVIDs that we've had in the past. It's just this was novel coronavirus 19. This was an unusual one. And I think it's going to be endemic.
I guess it feels a little bit like we're acting as if it is now endemic, even though it may not. We're not necessarily past the pandemic phase. But at what point would they say the pandemic phase is over and now we're in the endemic phase? Is there a criteria for that?
You're asking a question I don't know the answer for, and I'm going to give you a non-Washington answer and tell you I don't know.
That's good. That's allowed.
There are public health criteria, as you said, there are public health criteria as to what's pandemic versus what's endemic. Now, I will tell you that those public health criteria and who makes the call is the World Health Organization in Geneva, the United Nations Health Organization. They're the folks who declared this was pandemic. They will declare that the pandemic is over, and they will also declare that it's endemic or it's not endemic.
Okay. So during the early phase of the pandemic, a lot of people had a pod approach of the people that they would be around. Does that still work with, like if you have an immune compromised person with
Yes.
breakthrough infections as common as they have been?
Yes, yes. A pod approach where you try to stick within a group of people, all of who agree to be responsible and try to distance as much as possible, where you limit your contacts, and therefore, yes, that a pod approach is a great idea, especially for people who have malignancies.
Okay, great. And now is the mu variant still a concern?
It's out there. It is not a super concern right now, but it's certainly one to watch. And yeah, it's made one of the few good things about this whole mess is that we're all learning the Greek alphabet again.
Yeah.
Yeah.
Okay, this is a good question. So if you had the 3-dose vaccine and still got the Omicron variant, is it necessary to get a 4th dose targeting Omicron, or will the antibody levels from having had it be enough to keep you from getting it?
Yeah, when we have an Omicron vaccine, the recommendation is get the Omicron vaccine, even if you know you've had Omicron. Keep in mind, the one thing that we've seen with all of these viruses is the antibody levels and the ability to ward off the COVID goes down over time. So if you've had Omicron, your ability to fight off Omicron is going to diminish with time.
Mm-hmm.
That's why we want people to get another vaccine. In this case, have an Omicron vaccine, get an Omicron vaccine. If someone, especially someone who has immunosuppression, knows they had Omicron, we can now say 6 months ago, and they had their 3rd booster vaccine before that, they should talk to their doctor about whether or not they should get a 4th vaccine right now.
Okay.
Even though we don't have an Omicron vaccine available yet, it might be worthwhile to get a 4th vaccine.
Okay. I have a couple questions on Evishield, on the effectiveness of it, and is it recommended for cancer survivors who are more than 15 years out from treatment, or only for more recent cancer treatment?
I'm not familiar with that. Tell me a little bit more about that.
I don't know. I'm sharing questions from the audience that came in ahead of time. I don't know.
Mm-hmm.
Okay.
Sorry. I'll try to look that up and maybe get you something that you can put on your.
Okay. This is a pretty specific question, but I want to ask it. So can someone who's unvaccinated stay in the home of a vaccinated multiple myeloma autologous bone marrow transplant survivor who's been in remission for 12 years?
I hate to get involved with family dynamics and that sort of thing, but I think that's a risk to the patient who has had the myeloma. Multiple myeloma is a B-cell malignancy. The very cell that makes the antibody once someone gets vaccinated that protects the patient from COVID is the cell that was cancerous. So someone who has multiple myeloma, even though they are in complete remission now, has generated that their B cells have difficulty in functioning. And so you have someone who has a B cell problem, and then you're exposing them to someone who may very well be an asymptomatic carrier of COVID. That is great concern for me.
Yeah.
You know,
I mean, I think for me, even without a risk factor like that, I don't think I would have an unvaccinated family member and staying with me or a friend.
Yeah. Well, let's get very personal. A gentleman who I met a few times, Colin Powell, died of multiple myeloma and COVID. He caught COVID from somebody. You know, I don't know who, but he caught COVID from somebody. It was more than likely somebody who was not vaccinated.
Mm-hmm. Right. And his family stated that he was vaccinated, but because of his treatment, did not have the immune response.
That's right. That's right.
Let me look. I had another one. So you talked a little bit about things we may learn later that COVID caused. Do you think that the aftermath of COVID could create new strains of cancer itself, or what other kinds of chronic diseases could appear because of COVID?
One of the problems with COVID, by the way, how COVID kills people is they develop an inflammatory response. The immune system starts trying to attack the cells of the lung that are infected with COVID. And indeed, some of the therapies that we use to try to help people who are having a lot of difficulty breathing are steroids to blunt the immune response. Some of the IL-6 inhibitors that were developed for CAR T-cell therapy to inhibit IL-6, which is involved with the immune response. Now, so inflammation is really important in how COVID damages lung. Inflammation is also very important as a cause of a number of cancers. Men who have a history of prostatitis are at higher risk of prostate cancer. Number of diseases, number of cancerous diseases have now been linked to inflammation. There are some people who worry that people who got COVID are going to be at higher risk of lung cancer. I can only say worry right now, and I've given you the reasons why. It causes a lot of inflammation, and inflammation has been linked to cancer. Indeed, some of the mechanisms on how cigarettes cause lung cancers through inflammation, some of the mechanisms. So we do worry about that, especially with lung cancer, but who could, you know, we know that this thing gets into people's brains. That's why the people lose their ability to taste or their sense of smell. We know that this has been found in virtually every organ system of the body. So keep an open mind, and that's the reason why we're doing these cohort studies, to try to figure out early on if this is something that doctors and patients need to be on the lookout for.
Mm-hmm. Okay, so for someone who's very recently infected with COVID, since there's no way to test or identify the variant that they had, how do we know whether to proceed with the fourth shot now or wait for the fourth shot that's targeted to the variant?
I would track whether one gets a fourth shot. Well, number one, the fourth shot is right now only recommended for people who are immunosuppressed. Although I will tell you, I know a bunch of people who are not immunosuppressed who are getting their fourth shot because their booster was 5-6 months ago. Mm-hmm. But right now, only people who are immunosuppressed are recommended to get the shot. And I would use the time thing. If you're 6 months out from your booster and you're immunosuppressed, get the fourth shot now. Don't wait for a more Omicron-specific vaccine. You're probably going to end up getting that more Omicron-specific vaccine 6 months from now.
So should children ages 5 to 11 get a booster? I don't believe it's approved yet for that group, but do you think is that coming? It's
coming.
Okay.
It's coming. But by the way, keep in mind, the dose for kids 5 to 11 is different for the dose 12 and above. The vials are different color. So people administering the vaccine don't accidentally give a kid an adult dose or vice
Right.
versa. Yeah, but it's coming.
So that actually, I'm going to ask a specific question because I have an 11-year-old who will be 12 in a few months. And I
Should
worried
I
about
wait?
that. I worried that, he's getting like a third of the dose, but he's almost 12. So maybe I
Yeah.
wait till he's 12 and get him a booster that would be a full dose, or I don't know.
How long is the wait?
He'll be 12 in June.
So we're talking March, April, May.
Well, he's not eligible for a booster now anyway, but I guess by then he could get a booster for the 12 to.
Yeah, I would go ahead and give the kid the early dose and then hopefully try to catch up later on.
Yeah, well, he's already had the 2 doses at the the 2 initial doses.
Yeah,
But
if it were waiting 2 or 3 weeks, I might
Yeah.
do that. But if it's waiting 2 or 3 months, I would go ahead and give the pediatric dose.
yeah,
The other thing to remember is kids do, by and large, I've mentioned a couple of times, there are 1,000 deaths under the age of 18. Kids do, by and large, very well with this disease.
mhm,
Much less likely to have long-term COVID, much less likely to be hospitalized. Omicron, more hospitalizations than the others, but which is interesting because it's not that Omicron is more deadly or more likely to cause badness. It's just that more people got Omicron.
mhm. Yeah.
That's why hospitalizations went up. It was more people were infected because of the increased infectiousness. But I would go ahead. I would not delay a kid more than a couple of weeks in order to get the higher dose.
Okay.
One can also ask the question, what's the difference between 11 years and 9 months and 12 years?
Right.
Why don't we give the higher dose?
Yeah.
That I don't have any answer for that.
Is there a way to register to participate in one of the cohort studies that you mentioned?
I don't know offhand how one can. I know ASCO has one that's the American Society for Clinical Oncology has one for cancer patients, and that you have to go through your oncologist to get into. And if you ask your oncologist, that might actually move your oncologist to practice to start registering people. The ASCO literally to several hundred oncology practices across the country, and they're enrolling people to answer these questions. If you're not a cancer patient, I don't know the answer to that.
Okay. So what do rising cases and hospitalizations in the UK mean for the US? I think we already talked a little bit about this when I asked about the BA.2 variant, but is that an issue for us here? I mean, is that specifically that variant? Is that something we should be concerned about? Is that more of a concern for people who are unvaccinated?
It's much more a concern for people who are unvaccinated, but it is a concern for those of us who are triply and quadruply vaccinated. When I say concern, we need to watch it, hope that it dies out the way the old South African variant, and there was a Brazilian variant that also died out. But is it going to be a problem in the United States? The answer is a definite maybe.
Mm-hmm. Well, thank you so much, Otis. I didn't know if we would have questions to get us through to the end, but we kept having more questions roll in. But I really appreciated your time and your helping guide us through this again, because this is, I don't know, the 3rd or 4th webinar we've done, but the pandemic has changed and you've helped us stay on top of it.
It's always a privilege, and I'm going to find out the answer to the one question that I didn't even know the answer to. Okay.
Well, people commented that they appreciated the "I don't know" because you're right. That's not a very Washington answer. It's usually a BS, like that you think you know and you don't really know. So it's nice to just say "I don't know" and I'll find out. So thank you.
Thank you. You take care.
Thanks everybody for joining us. Have a great day.
Bye-bye.